Hello, everyone. My name is Brus Layson with Torrentia Medical Education, and I'm here with Ray Butts with Torrentia as well. How we doing, Ray?
Good. Thanks, Bruce. Thanks for having me back. I understand we're talking about dry needling today.
We are. I'm very excited about that, and I know that you can get a little carried away when we start talking about pain dry needling, but I'm here to direct you a little bit and a couple of questions we've gotten for some people as we're starting to release some more of this content. So, Ray, let's start real general and we'll kind of break it in here. So,
Fair
in
enough.
general, how does dry needling help with pain?
Well, that's probably the most loaded question of all time. Let me give you a couple of highlights that you most often see in the literature. I think there's a really fair argument for how we can needle patients and increase opioids in their body. It's important to say, though, that you don't just stick needles in patients, use manual and electric stimulation, and get opioids. Rather, when you needle patients, we get something called endogenous anandamide. You actually get the body to make more endogenous anandamide, which isn't opioids. Rather, it's the instructions to tell the cells of the body, any cells that can actually make opioids, that they should make more opioids and then release them in order to take the pain away. In fact, we know that any cell that has a CB2 receptor in the body, and the classic ones are usually leukocytes, that's usually the white blood cells, are able to receive endogenous anandamide. And when that happens, it's kind of like telling the cell, look, I don't know what your job is, but whatever you normally do, cease work. And instead of that job, I want you to become an opioid manufacturing machine. So it essentially drives a cascade of events to get those cells to make more opioids. And as they make those opioids, they release them into the environment. And then those opioids are recognized by opioid receptors, which in turn inhibit pain. So we definitely, with needling, get a big time opioid response.
But
What we
what about
also
gate theory?
Yeah, so that one's fair too. I would say most people, if they know about any sort of pain relieving mechanism, they like to talk about the gate control theory of pain. Usually, we see that with interferential current, we see it with TENS, but absolutely, when you use electric with needles, we definitely elicit the gate control theory of pain. Now, I think a reasonable question to ask is, well, how does that happen? And what's interesting about gate control theory is it really has to do with the tips of the dorsal horns, which make up the gray matter, which kind of looks like a butterfly in the spinal cord. Those tips of the dorsal horns is a place called the substantia gelatinosa. And what's interesting about that part of the gray matter is that we know that it's loaded with interneurons, interneurons which do what interneurons always do, which is inhibit stuff. They essentially make inhibitory neurotransmitters, GABA, glycine, etc. And those neurotransmitters really have one job in life. They're supposed to inhibit the dorsal horn neurons from receiving pain information from the periphery and then delivering that pain information up to the brain so that you could actually interpret what that pain is. You can imagine, like, the less or the more that you inhibit those dorsal horn neurons, the less that you're able to transmit pain, right? Those interneurons of the substantia gelatinosa are kind of our friend, right? They're the reason why our first response to pain isn't really pain, it's kind of the inhibition of pain, right? But the problem with those interneurons, as I like to say during class, is that they're kind of lazy. They get really tired really fast. And when they do, they kind of give up. They go back to bed, so to speak. And now it creates a situation where pain has uninhibited access to get from the periphery directly into the central nervous system. We essentially disinhibit those spinal segments to being able to receive pain, right? And so, well, what do we do in order to fix that? Well, we either put the pads on the patient, right? Interferential current TENS, or we add electric to needles. And the reason why we do that is because we're trying to stimulate A beta pain fibers. Why? Because we know that A beta pain fibers specifically stimulate the interneurons of the substantia gelatinosa. It essentially sneaks into their bedrooms. It pulls them out of bed. It gets in their face, sticks a finger in their face. It's like, look, you're a lazy piece of poop. And we got a patient that has pain. And I don't care if you're tired or not, you need to do your job, right? Even if you have to work overtime, you need to do your job. Like essentially, A beta pain fibers is the same as sticking a funnel into the mouths of those interneurons and pouring down a bottle of Red Bull or a can of Celsius, right? It essentially gives those interneurons wings and it gets them to do their job in an exaggerated way, right? What's their job? Well, it's to make extra inhibitory neurotransmitter, which essentially inhibits those dorsal horn neurons from being able to receive pain. And in doing so, it essentially slams the gate shut on pain information going from the periphery into the central nervous system, right? If you block the receiving and the transmitting of pain up to the brain, you essentially can't feel pain, right? That's the premise of the gate control theory of pain. And certainly we know that we get that when we use needles with electricity.
And as I always say, in short, the excitation of inhibition.
That's exactly right. Yeah. Now, I think there's an even stronger argument to be made, though, which has the same logic, which is kind of the way that pain is normally managed at the level of the spine. And that's diffuse inhibitory noxious control. We know that when we needle patients with lots of manual and electric stimulation, we also stimulate not only A beta pain fibers, but also C fibers and A delta pain fibers. And that information goes from the periphery through the dorsal root ganglia, in through the dorsal roots. It's received by the neurons which live in the dorsal horns of the gray matter. And then from those dorsal horn neurons, it essentially travels up the axons of those dorsal horn neurons, which is the spinal thalamic tract, on the way to the brain. But on the way to the brain, it seems that those C fibers and those A delta pain fibers, they kind of take a pit stop in the brainstem. And in the brainstem, they activate a very special part of the brainstem called the periaqueductal gray. That's a very interesting part to stimulate because we know that when you stimulate it, you essentially get two things. You get more serotonin and more norepinephrine. Serotonin and norepinephrine are the primary neurotransmitters that are responsible for managing pain in the spine. Why? Because serotonin and norepinephrine then travel down the spine and they essentially go to the dorsal horn neurons themselves and they work one of two ways. Either they stimulate the interneurons that live among the dorsal horn neurons, right? And when they stimulate those interneurons, they get them to make more inhibitory neurotransmitter, which is in turn received by receptors that live on the dendrites of those dorsal horn neurons or that live on the axons that come from the dorsal root ganglia. And when they receive that neurotransmitter, they inhibit. They essentially inhibit the dorsal horn neurons from receiving pain, and they inhibit the dorsal root ganglion neurons from delivering pain, right? Even if they don't work via interneurons, we also know that there are serotonin receptors and norepinephrine receptors, which live on the dendrites of the dorsal horn neurons themselves and live on the axons, which come from the dorsal root ganglia. In which case, serotonin and norepinephrine can also directly inhibit the receiving of pain information into the central nervous system and the delivery of that pain information up to the brain. The point is this: by getting more serotonin and norepinephrine via diffuse inhibitory noxious control, you essentially decrease the ability of pain being delivered into the central nervous system and pain being delivered from the spinal cord on up into the brain. If you can't receive as much pain and you can't deliver as much pain, you can't feel as much pain.
It's really
That's
cool.
another really interesting mechanism.
I always talk about with my patients the thalamus essentially acting as the junction box that's receiving all different types of stimuli throughout the body. And what you're talking about with the perioctave ductal gray and taking the spinal thalamic tract, we're essentially able to repackage a stimulus differently, which then promotes a different cascade of event of endorphins throughout the entire body.
I mean, that's true. If you think about the thalamus is almost like the switchboard or the operator of the cortex, right? Anything that gets transmitted, let me say that differently. Most, especially of pain information that gets transmitted up to the cortex, has to go through the thalamus. And when it gets to the thalamus then sends it to lots of different places, right? So essentially, what I'm describing to you via diffuse inhibitory noxious control and the gate control theory of pain is the equivalent of sending less information to the switchboard. If the switchboard or operator is getting less pain information, they have less pain to actually send up to the cortex where that pain is interpreted,
Gotcha. I mean,
right?
it's crazy to think about, within our scope of practice as physical therapists and chiropractors and rehab providers, like we have the potential to do this with our patients, and it's
For sure.
cool understanding that.
For
But
sure.
okay, let's stay on dry needling.
Well,
Let's stay on dry needling here. Let me
for
ask you.
sure, for sure. I
Um,
want to talk about another mechanism, which one of my favorite mechanisms to talk about when it comes to pain reduction and needling, and this really has to do with adenosine.
okay.
So we know that when we needle our patients, that one of the primary receptors that we are after with needling is one of the only receptor types that we have on our peripheral neurons that is responsible for mechanical stimulation, which is known as a TRPV receptor, right? For that reason, TRPV receptors are often referred to as the acupuncture receptor, or you could say the dry needling receptor. In other words, we put the needle in, we wind the needle, or we mechanically stimulate the needle, and in doing so, we activate that TRPV receptor, usually TRPV1 receptors, depending on what peripheral neuron that we're talking about. When that happens and the TRPV1 receptor becomes excited, it opens. And when that receptor opens, it allows ions to move from outside of those peripheral nerve endings to inside. One of the primary ions that moves into those peripheral neurons are calcium, right? And that's really interesting to talk about because we know that one of the primary things that calcium does as it moves into cells is it kind of kickstarts or it cranks up the engines of the mitochondria. Why? Because we know that calcium is one of the primary things that's responsible for the enzymes of the mitochondria to make it work, right? Well, we know that the more that the mitochondria works, the more ATP that we get. That ATP is energy, which is really great, right? The problem is that eventually you're going to get the mitochondria to make so much ATP, it's going to be more energy than what that cell needs. And so the more ATP that you make, you reach the threshold where some of that ATP then is going to be dumped out of the cell, right? And so essentially what you end up with, if you can imagine a big pile of ATP just sitting on the outside of the peripheral nerve endings. And that's interesting because as that ATP begins to pile up, your body responds in an appropriate way, which is essentially to break that ATP down, right? We got to break it down. We got to get rid of it. We have to clear it, right? And there's an entire pathway that is responsible for that, right? We break down ATP from ATP to ADP to AMP to ultimately adenosine. Now, not only is that adenosine interesting, but the pathway to get there is also interesting, right? Why? Because we know that ATP that sits on the outside of our peripheral nerve endings activates a very special receptor type called a P2X receptor. P2X receptors are ionotropic receptors, meaning that when they open, it allows additional influx of ions. Now, that's interesting for two reasons. Number one, we know that when we activate P2X receptors, it does cause a little bit of discomfort, right? But we also know that when we stimulate P2X receptors, we also begin to drive very specific cascade of events like the ERK pathway or the AKT pathway, which are the pathways that are responsible for the transcription factors that are really responsible for transcribing the parts of the genes to create the proteins that are necessary for regenerative medicine. These are really the proteins that are responsible for proliferation and differentiation and migration, right? Which essentially helps us to drive the repair of the tissue that we're looking for, assuming that we have damage, right? But remember that just the activation of P2X receptors causes pain. Then, as as ATP continues to break down to ADP is able to stimulate another receptor type called a P2Y receptor. P2Y receptors they're not ionotropic, they're metabotropic receptors, which means that they work based on G proteins. And in doing so, it's interesting to talk about P2Y receptors because we know that P2Y receptors via G proteins allow the release of calcium from the internal storage warehouses of the cells, which essentially eventually stimulate or also stimulate the ERK pathway and the AKT pathway, which are responsible for the very same transcription factors that transcribe the proteins that give us the effects of regenerative medicine. But also, when you stimulate P2Y receptors, that also causes pain. So let's take a step back, right? We initially got mitochondria to make more ATP by the mechanical stimulation of the needling itself, which was dumped out of the cells. And now that begins to break down. ATP on the outside of cells activates P2X receptors, which causes pain. Then ATP breaks down to ADP, which activates P2Y receptors, and that causes pain. And then it breaks down from ADP to AMP and ultimately adenosine. Adenosine is really interesting to talk about because we know that once you get to adenosine, adenosine is recognized by A1 adenosine receptors, which ultimately blocks a very special enzyme called adenocyclase. And you could say that adenocyclase is one of the most important enzymes that's responsible for the cellular architecture of delivering pain. In other words, cells really rely on adenocyclase to deliver pain from the periphery to the central nervous system. Why? Because adenocyclase is one of the primary enzymes that is responsible for something called hyperalgesic priming. The more adenocyclase that you have, the more of the cascade of events that you drive, which ultimately gets you to something called PKC epsilon. And that PKC epsilon essentially drives long-term potentiation in the periphery, which upregulates all the pain receptors that peripheral nerve ending has to receive pain, and it exaggerates the sensitivity of all of those receptors. Well, the more receptors that you have and the more sensitive of all those receptors are, the more pain information that you're going to receive with those peripheral nerve endings and then deliver centrally, right? So my point is this. The more adenosine that you can get by breaking down ATP, the more that adenosine will block adenocyclase. And in doing so, you essentially disrupt the primary mechanism that is responsible for the hypersensitivity that occurs in the periphery, which is ultimately responsible for delivering pain centrally. Now, here's the best part. Because in order to get that adenosine, I had to break down ATP into adenosine. But all along that pathway, the activation of P2X and the P2Y receptors causes discomfort. And what's interesting about that is that discomfort is often, or what is widely accepted as to be the cellular explanation of what deqi pain is. Deqi pain is the primary variable throughout hundreds of years of acupuncture that is meant to be that deep pressure, that spreading warmth, that deep ache, the reproduction of the patient's symptoms when they have it, right? That you putting the needle in when you do dry needling and the patient saying to you, wow, like you hit the spot. You're actually reproducing my symptoms. You hit the bullseye of my problem, right? My point is it's the reason why when we use dry needling that we have to use manual and electric stimulation because that manual and electric stimulation is primarily the reason, well, let me say that differently. That manual and electric stimulation, we're primarily doing it to elicit qi because that is really the only way that we know that we have elicited an appropriate dose to get the cells to make ATP from their mitochondria, dump it out so that that ATP can break down to adenosine. In other words, another way of thinking about qi is that it is really the only way that we know that when we use the needles, right, that the cells in the tissue that we're needling actually heard the instructions that we're trying to give them with those needles, and that those cells are actually doing what we need, right, on a cellular level to produce ATP and break it down to adenosine, which ultimately helps to take that patient's pain away. It is one of the primary reasons why qi is the most important variable, arguably, throughout the entire acupuncture profession, right? And it's one of the most important correlates of whether the treatment is going to work or not work. And from a dry needling perspective, it's one of the primary reasons why the treatment that you provide with manual and electric stimulation needs to be a little bit uncomfortable because that discomfort is representative of that qi, and that qi is representative of the production of adenosine, which will ultimately take that patient's pain away.
So let's make this a little bit clinical, okay? So you're telling me none of this is happening unless the mechanical stimulation of TRPV1 receptors occurs. Is that correct?
That is correct.
Okay. What is the threshold then of mechanical stimulation that needs to occur for that to happen? I mean, can I just put a needle in and I can expect this cascade of events to occur?
Well, in some cases you can, right? Because in some cases you have a patient that is very hypersensitive, and that's all you need to do, right? But what you're really asking me is that the only way that I know is if I'm able to elicit a response from the patient that is strong, a little bit uncomfortable, but maybe not nasty painful. Something where I'm able to elicit the sense of a deep ache. I'm able to reproduce their symptoms. Like all of that put together or packaged is essentially qi, right? The point is the only way that I know that I've activated TRPV1 receptors, wait, which is essentially the primary thing that is necessary to drive the cascade of events that is necessary to get to the adenosine, is if the patient reports to me that qi response. What you do with your manual stimulation of the needle, or what you do via your electric stimulation of that needle, is really going to be patient dependent, right? Because at the end of the day, it really depends on how sensitive that patient is, right? But you may need to do less manual and electric stimulation with a patient that is more sensitive, right? Or you may need to do more manual and electric stimulation with a patient that is less sensitive, right? But ultimately, what you're trying to achieve is the same feeling that the patient reports. And that feeling, AKA deqi, is the only way that I know clinically that I have activated TRPV1 receptors and that the process that is responsible to get to adenosine is ultimately in play to help the patient, to help to take the patient's pain away. Now, here's the best part, Bruce. I know last time that we talked a lot about Shockwave. And one of the primary mechanisms that we talk about with Shockwave is also mechanotransduction. And when we talk about shockwave, we don't really talk about TRPV1 receptors, but what we do talk about is integrins. And when we stimulate integrins, we know that that also leads to the production of more ATP from the mitochondria in those cells. And that ATP then is dumped out, which essentially gives us the same chain of events. And we know that by stimulating integrins via shockwave, that the ATP breaking down outside of those cells after we produce it activates the very same P2X and P2Y receptors. And when we talked about it with shockwave, the activation of P2 and P2X and P2Y receptors gave us it kickstarted the cascade of events that we talked about as the ERK and the AKT pathways, which were the very cascades that were necessary to give us the transcription of the parts of the genes that got us the proteins that were responsible for regenerative medicine. My point is this: dry needling and shockwave mechanistically really go hand in hand. In fact, on a cellular level, you could say that they really do work additively. Even though the target is different, they ultimately end up stimulating a lot of the same receptor types, which works additively to have the same effect. What are those effects? Well, one is pain reduction, but the other are the cascades associated with regenerative medicine. It's the reason why I think clinically, more often than not, the mechanotransduction that we see with dry needling works hand in hand with shockwave. And if we do both of those together, I think that we can oftentimes exaggerate the results that we're trying to achieve clinically.
Our pathways to ATP are different in getting that adenosine, stimulating that adenosine production and breakdown, essentially. But the end result is the same. Through we meet the same pathway, but to get there, totally two different ways.
You got it.
Very, very
That's
fast.
exactly it. That's exactly it.
I
What
love the tie into regenerative medicine there too, Ray. I mean, we talk about that so much all the time, but dry needling is such an important aspect of that too.
I mean, let me just make one more point about pain that I think is interesting for people to hear. You know, a lot of times we talk about this term deqi, which clearly comes from the acupuncture profession. But if you want to demystify that a little bit, right? The studies that have really looked at what deqi pain actually is, right? What you find is that the majority of it is actually A delta pain, right? And
Right.
that's really interesting to talk about because we know that A delta pain, aka deqi, is what is primarily responsible for, in many cases, undoing the changes that you see occurs in the spinal cord that is associated with the changes of central mediated chronic pain, hypersensitivity, hyperalgesia, allodynia, right? And we get many of those changes via what's called wind-up pain or C fiber pain, right? But we know that the more deqi that we're able to elicit over time via manual and electric stimulation and needling, the more that we're able to stimulate A delta pain fibers. And by doing that in a way which is tolerable, we can use that tolerable A delta, deqi, right, in order to reverse the changes that were originally created in the spinal cord by wind-up C fiber pain. And another way of saying that is that we can essentially use A delta deqi stimulation to reverse hypersensitivity, hyperalgesia, and allodynia. And we now know from a lot of the shockwave literature that one of the primary ways that that happens is we can use manual and electric dry needling in order to tone down or quiet the microglia that live in the spinal cord that bias the changes which occur in the dorsal horn neurons that are responsible for the changes associated with central mediated chronic pain. In other words, by stimulating deqi, right, in the way that we just talked about, not only do you get more adenosine, but we can use the very same deqi as a delta stimulation to ultimately quiet the microglia, which are the cells in the spinal cord. And those cells are the very cells that drive the changes of the dorsal horn neurons that are responsible for hypersensitivity, hyperalgesia, and allodynia. The more that you can quiet those microglia, the more that you can reverse those changes. It's one thing just to treat pain via adenosine. It's another thing to treat the changes which occur centrally associated with central mediated chronic pain.
I feel like we've had a couple discussions about that over the last couple of days. Okay, I'm gonna keep us rolling here.
Okay.
You've talked a lot about the different pathways, different types of pain. You know, we talked into adenosine and TRPV1 receptors, and you've mentioned acupuncture a lot. I want to ask you this. When I see acupuncturists, a lot of the times, let's say a patient has neck pain, physical therapists, chiropractors, and us in the rehab world, a lot of times, oh, they have, tension headaches or cervicogenic headaches or the suboccipitals, we want to put our needles there. We want to be in that area. That's where our, pain generating structures are. And yet, acupuncturists, I'm seeing them put things in the arm, in the hands, in the leg,
Yeah.
in the shins. I mean, it works. It works differently. It's a different world than what we're used to. Why? What's going on there?
Yeah, so this is kind of a different mechanism, and I think the way acupuncturists would explain this is a little bit different than what I'm about to say. But when you think about how needling is able to treat pain, I think there is a really good argument for needling at the site of pain, but also needling away from the site of pain. And the best explanation here has to do with the way or the difference that you process pain and how that's different than how you process itch, right? The mechanism of itch and pain kind of play off of each other in a really important way. How does it work? Well, we know that when we put needles into patients, not only do we have an effect on the peripheral nerve endings, we also have an effect on mast cells. And what's interesting is the way that we have an effect on mast cells is very similar to what we just talked about on peripheral nerve endings. How? Well, the receptors that we're after are a TRPV2 receptor, not a TRPV1 receptor, which is what you saw in the peripheral nerve ending. On
What's
mast
the
cells,
difference, Ray?
it's the same family, right? It's just a different number because it's a receptor which is found on a different cell type. And what's interesting about that is remember, that's one of the only receptor types that we have in the periphery that is responsible for mechanical stimulation. Again, the reason why we put needles in and wind them, and why we use electricity is to mechanically stimulate tissue to be able to have an effect on these different receptor types. When you activate TRPV2 receptors mechanically on mast cells, it causes mast cells to degranulate, meaning the plasma membrane disintegrates and the stuff on the inside comes out. Well, one of the things on the inside of mast cells is histamine. Well, what do you know about histamine? Histamine causes an itch, right? That should kind of make sense to you because, well, when you have a mosquito bite or you have an itch, what do you do? Well, what you could do is you could go to the drugstore and you get an ointment or a cream, which is an antihistamine to block the itch, right? So my point is not only are we using needles in order to have an effect on peripheral nerve endings, we are also getting histamine from mast cells. And so if you needle and open mast cells at the same place as pain, that means that pain and itch via histamine travel along the same pathway, right? Let me say that differently. That means that itch and pain, they travel along the same pathway to get into the central nervous system at the same spinal segment. And if that's the case, if itch and pain go into the central nervous system at the same spinal segment, then we know that in the spine, pain always wins out over itch. That should kind of make sense to you because when you have an itch, what do? You scratch it. Why do you scratch it? You scratch it in order to create a pain response because we're essentially using pain to inhibit itch. However,
Pretty cool.
we also know that if you put needles in at a site which is offset from pain, right? Now you can elicit an itch response in a different place than the pain response, which means that now itch and pain are going to travel and get into the central nervous system at different spinal segments. If pain and itch go into the spinal cord at different spinal segments, that means that pain no longer can inhibit itch, which means now pain and itch are able to travel uninterrupted all the way up to the brain. If that's the case, in the brain, if pain and itch are able to get there, then we know that in most of the parts of the brain, to include the supramammillary nucleus of the hypothalamus in the brain, itch wins out over pain. In other words, if pain and itch can both get to the brain, now we can use itch in the brain to inhibit pain.
Very
There's your justification for needling at the site of pain, but also needling away from the site of pain. Because away from the site of pain, you essentially elicit the histamine, which causes an itch response. And ultimately, we use that histamine in the brain to block pain centrally. It gives us the ability to make the argument that we could use needling with manual and electric stimulation to block pain peripherally at the level of the spine and also in the brain, which is another reason why we can make the argument when it comes to dry needling with manual and electric stimulation that not only can we use it to treat how pain is transmitted in the brain, but we can impact the parts of the brain that are not only responsible for how the pain feels, but also the emotional and the behavioral aspects of pain, or the parts of the brain that are responsible for psychosocial pain. In other words, there's a really good argument to be made for using dry needling with manual and electric stimulation, not only to treat pain, but also to treat psychosocial pain and do it in a way which is measurable.
That's a lot. That's a
Well,
lot.
have you met me?
I love it though, man. I mean,
You know I'm a lot.
Let me make it a little bit, let me get a little more clinical. And I don't know the answer to this question. Maybe you do, maybe you don't. I'm going out in left field here a little bit. Why is it that there's certain spinal segments that are chosen versus not all of them? I mean, it's not like I'm going S1, 2, 3, 4, L5, 4, 3, 2, 1, T12, 11, 10. I'm trying to flood the brain with histamine to block it, with a swarm of, cells coming in to wipe it out. It's always very selective. I mean, I may put us down a rabbit hole here, but I really do want to know the answer to this question. I have a feeling where you're going to start, but
Well, I think what you're asking me is why are some distal points more powerful than other distal points? And I what it has to do with is it's not the spinal segment that is ultimately the reason for that. It's where those distal points are in the periphery, which essentially exaggerates how much or how exaggerated the effect will be of those points in the brain. And that has to do a lot with, you know, those points. Remember, this is getting much more into acupuncture, which I is not as appropriate for our conversation, but
fair.
it really has to do with the overlap with the nerves in the area and a lot of not only the neural effect that you have, but also the immune effect that you have, and then also the connective tissue that you have, right? And so the more of those things that overlap in the periphery, the greater the exaggeration will be in the brain, right? And so, really, what you're looking for is as much of that overlap as you possibly can find, which is which is the correlation for why some of those points are more important, right? So in the literature, what I just described to you in a more simplistic way is often referred to as the acupuncture unit or the acupoint unit, right? It really looks at this layered sort of physiology that you see on some points more than others.
I hear that. I do think it's we teach and we practice dry needling, but I do think it's very important for us to heavily understand and study the literature, as I know you have as well, Ray, of other practices related to our field, though, for sure. So
For sure. With respect, for sure.
I appreciate the indulgence in that question. So I got a few more here, okay? And these are more so toward, questions people have really been asking us a lot about. There's three things. I want to know dry needling, neuromuscular junctions. I want to know dry needling, tissue remodeling, and dry needling, neural repair. Let's take one at a time. Dry needling, neuromuscular junctions. What do you got for me, Ray?
Yeah, so I mean, it's one thing to talk about needling and pain nerves. It's another thing to talk about needling and the effect that you're able to have on alpha motor neurons that are responsible for the stimulation of muscle fibers. And now we're talking about neuromuscular junctions. So this kind of gets us back to, another aspect of dry needling, which is intramuscular trigger point dry needling. And I think this is what most physical therapists, maybe not most, but a lot of physical therapists think about when they think about needling, right? I would love it if our profession could, look at it in a much more broad way because I think it would be ultimately more powerful, right? But let's just say it, intramuscular trigger point adrenaline is really meant to treat trigger points which occur in muscle, right? And one of the primary ways that we do that is by resetting the neuromuscular junctions. So think about it. One of the primary ways that we get to trigger points is via an energy deprivation. And we talk about this a lot in class, right? We can get an energy deprivation a lot of different ways. You can talk about it as damage and inflammation. You could talk about it as excessive fibrosis and scar tissue, maybe poor biomechanics, but essentially via all those different mechanisms, and I'm sure that there are others, we start to block or impede the blood flow in the microvessels that are responsible for bringing oxygen and nutrients to different aspects of muscle tissue. And when this happens, now we have different parts of the muscles that are like, holy poop, like here I am, and now you're taking away my blood flow, you're taking away my oxygen and my nutrients, what the poop, right? And so when that happens, the muscle begins to panic. And when it does, it wants to tell the central nervous system, hey man, we got a problem, right? I'm not getting enough blood with oxygen and nutrients. To tell the central nervous system about that problem, the only way that muscle can do it is it has to release chemicals. Chemicals like bradykinin, substance P, CGRP, lots of different interleukin factors. If I take all those chemicals and I put them together, those are all kind of factors of inflammation, right? And a lot of those factors of inflammation collectively drive the pH down and make the environment more acidic, right? So if you think about the increase in acidity and if you think about all those different chemicals, understand they wreak havoc at the neuromuscular junctions. What do they do there? Well, the best argument is that they begin to break down or disable an enzyme called acetylcholinesterase. Acetylcholinesterase has one job in life. It's supposed to break down and clear any acetylcholine which is left in the neuromuscular junctions, right? And it either gets rid of it or it puts it back into the axons of the alpha motor neurons so that it can be used again. Without that acetylcholinesterase, you can't do that. Well, if you can't do that, that means you can't clear acetylcholine. If you can't clear acetylcholine, it essentially just sits there. And so not only does it just sit there, but it begins to collect and add more and more and more. Why is that a problem? Well, remember, acetylcholine is the primary neurotransmitter that is released by alpha motor neurons, right? That essentially provides instructions for muscle fibers to fire. So if that acetylcholine is always there, the instructions to tell muscle fibers to fire is always going to be there, which essentially means now that those muscle fibers are going to start to fire over and over and over again because of that acetylcholine essentially driving a cycle of hypertonicity. Parts of muscle that is firing more than what it should be at rest. And you could think about that hypertonicity as the physical properties that you typically think about when you think about trigger points. The part of the muscle which is angry and aggravated and pissed off, where everything around it is soft and squishy and relaxed because it's continuously working, it's overworking, it's overfiring, right? So one thing that we really try to do with needles is to correct that. How? Well, we take needles, we try to put it into trigger points so that we can essentially stimulate the peripheral nerve endings that we find in those trigger points. Why? Because by stimulating those peripheral nerve endings, we want that information to go from the trigger point in the periphery to the dorsal root ganglia, and from the dorsal root ganglia in through the dorsal roots, and then eventually into the dorsal horn neurons. Not necessarily so those dorsal horn neurons can deliver that information up to the brain, but so that those dorsal horn neurons can also deliver that information to the ventral horn neurons, which is where the alpha motor neurons live, right? We essentially want the pain neurons to deliver that pain information from the needle to the alpha motor neurons so that that stimulation, right, will stimulate the alpha motor neurons and drive excitability down the axons of those alpha motor neurons so that eventually that excitability will hit the neuromuscular junctions, and in doing so will help to use up or to eliminate or to clear via that excitability the excessive acetylcholine that you find in the neuromuscular junctions as a result of the energy deprivation, right? By clearing that acetylcholine via the needle, we essentially then are trying to break that cycle of hypertonicity, and in doing so, get that hypertonic part of the muscle, the trigger point, to relax, right? And in doing so, we're trying to disable the trigger point. But if you think about it, We're disabling the trigger point by resetting the neuromuscular junctions, resetting it so that now we can drive a normal amount of acetylcholine so that it's working appropriately again, right? Now, it is worth pointing out that what I just explained to you is essentially the meaning of the localized twitch response. But also remember that when we needle patients, we get a significant increase in blood flow. You get a significant increase in perfusion of blood through that tissue, hyperemia. And so what you also find is not only do you get the stimulation of the alpha motor neurons via the localized twitch response to use up the acetylcholine, but this tidal wave of blood that you just caused essentially washes through the tissue. And when it washes through the tissue, it washes out not only the acetylcholine from the neuromuscular junctions, which is there in excess, but it also begins to wash out the chemicals originally released by the muscle as a result of the energy deprivation, which caused the problem in the first place. So it's really thought to be an additive effect. The localized twitch response and the increase in blood flow helps us to change the environment of neuromuscular junctions, which essentially, which we do essentially by breaking the cycle of hypertonicity, which essentially gives us the physical properties that you and I think about when we think about trigger points.
The classic example by Ray Butts. I'm going to keep you rolling. Okay.
Well, let me just say one more thing about the neuromuscular junction, because also consider that the reason why we use electric with needles is also so that that stimulation can travel down the alpha motor neurons and stimulate muscle fibers. Why? Because we can use that electricity to get those muscle fibers to release two things in the main: brain drive neurotrophic factor and neural growth factor, which are two neurotransmitters which feed back to the alpha motor neurons and essentially elicit the long-term potentiation on a genetic level in those alpha motor neurons, which is ultimately responsible for the changes that we see in the axon of those alpha motor neurons. And those changes allow us to change the geography of the neuromuscular junctions in a way where we can begin to change or reorganize motor units.
Mm.
By changing motor units, that essentially gives us the ability to elicit neuromuscular reeducation, right? So please don't forget about that too. Certainly, that is also happening when we do electric dry needling. I mean, you can talk about pain, but the ability to change motor units at neuromuscular junctions so that we can get alpha motor neurons to have more efficient reach and greater reach to muscle fibers and maybe even muscle fibers of different muscles gives us more coordinated movements, which has to happen before we get to increased strength and hypertrophy.
Legislatively, in my involvement in the American PT Association world, I know this is the number one validation of working toward insurance companies of utilizing dry needling as neuromuscular reeducation. I know there's a lot that's talking about that from a validation standpoint.
I mean, we just have to be able to understand the physiology and explain it better. And to your point, I mean, the other thing you asked me about was about using needles for tissue remodeling. And that's really important to talk about too. A lot of the literature isn't just about pain, but it's using needles with manual and electric stimulation to actually make the tissue look different, to look like it looked when it was normal, like before the problem was there, before the injury was there, right? So there is another, I mean, a huge part of the literature that is associated with using needles to remodel tissue. And we know that one of the ways that we're able to do that on a genetic level is by getting cells mechanically to make more enzymes. Specifically, Rowan rat kinases. Rowan rat kinases essentially break down or allow us to change the actin cytoskeleton of cells. It allows us to change the skeleton of cells, which essentially means that by changing the skeleton, we can change the way that cells look, the way that they're laid out, the way that they are they round, are they elongated, right? It allows us, and by changing the shape of cells, if we can change the shape of a whole lot of cells, that is essentially another way of saying that we can remodel tissue. Now, here's the best part. We know that the way that we get a lot of these enzymes, like Rowan rat kinases, is via the stimulation of integrins, which essentially activates the ERK and the AKT pathway. Now, we talk a lot about integrins with Shockwave, right? Let's take a step back and just remember what integrins actually are. Remember, integrins are essentially little antennas which stick out of the plasma membrane of cells, which essentially connect the skeleton of the cell itself, the actin cytoskeleton of cells, with everything structurally which occurs outside of cells. Collagen fibers, anything which is in the extracellular space, right? That is essentially what an integrin is. And we know that when we do shockwave, that we essentially use that wave of energy to mechanically disrupt the extracellular space or to mechanically disrupt the actin cytoskeleton, which ultimately activates integrins. And those integrins then activate those cascade of events, which give us the transcription factors, which transcribe the enzymes necessary to change what those cells look like and change their orientation and remodel the tissue. Here's my point. There is a ton of literature that shows that needling with manual and electric stimulation gives us the very same enzymes, which allows us to change the shape of cells and remodel tissue. A lot of that evidence comes from the work of Helen Langevin at Harvard. My primary point is this. If that's the case, it means that the only way that that's possible is if when we needle patients with manual and electric stimulation, it means that the only, it means that TRPV1 receptors cannot be the sole receptor that is the target. It means that the only way of what I just said to you can be true is if needling like shockwave, when used with manual and electric stimulation, also gives us the mechanotransduction, which is able to activate integrins too.
Would you characterize this as angiogenesis like in Shockwave? I mean, we're getting the adenosine, we're getting the pain reduction, and we're getting the integrin remodeling perspective. But are we
Well,
getting that component also?
I mean, remember one of the very best reasons, one of the strongest reasons of why we would needle with manual electric stimulation is in fact an increase in blood flow. We just talked about that. And we know that needling is responsible for angiogenesis. We talked about this last time that you and I talked. We know the only way they get to angiogenesis is we know that genetically, via the ERK and the AKT pathway, we have to have more transcription of nitric oxide synthase. We have to have more VEGF, and we have to have more SDF1, which beacons stem cells, specifically endothelial derived stem cells, to come from the bone marrow to the tissue so that those three things together can then lay down new blood vessels, which is exactly what angiogenesis is. My point is, it is the very same mechanism that's responsible for the transcription factors of angiogenesis is the very same cascade of events that is responsible for changing the actin skeleton of cells to change the shape of those cells, which allow us to remodel tissue, which ultimately gives us the ability to use needles to make tissue look like it looked before the problem was there in the first place. And my point is, we can talk about TRPV1 receptors all day long, but there's no way that the mechanotransduction of needling with manual and electric stimulation does not also have the ability to stimulate integrins in the same way as shockwave, which
Powerful.
means that not only is it a pain relieving effect, but what I'm describing to you is the cascade of events which gets us the genetic effect of tissue change and repair.
Okay. Pushing you forward, neural repair.
Well, we just talked about the neural repair at the neuromuscular junctions. I mean, that was the point about using the electric stimulation to be able to get the muscle fibers and honestly, nerves can also release it. Um, but anytime that you have the release of neurogrowth factor and or brain-derived neurotrophic factor, those are really the primary neurotransmitters that are responsible for the cascade associated with long-term potentiation. And that long-term potentiation is really what genetically allows us to make the neural repair, even so much as it is the very same neurotransmitters that activate the Schwann cells and the oligodendrocytes to work overtime in order to remyelinate axons that had been injured, which is one of the reasons why you see in the literature electric dry needling has the ability to repair nerves that have been injured not only in the periphery via Schwann cells, but also centrally in the case of MS by activating the oligodendrocytes to remyelinate those central neurons, putting patients back into remission and being able to giving us the ability to treat those patients as well. So look,
Cool.
I
So
think that to be honest with you, Bruce, I've already taken it too far. Um, I think when it
well,
comes to needling, I mean, those are really most of the high points that I think I would like people to know about, or at least think more about. Um, and even if they didn't understand all of that, hopefully it will at least generate some questions and I can make things more clear.
yeah.
But I just, you know, I think in summation, I just want people to understand that there's so much more going on with this really powerful tool that we know as dry needling, especially if you use it in a intramuscular trigger point dry needling way, and if you use it in a winding way, and you use it as in a by adding electricity to it, like there's there's just so much going on, more going on physiologically, whereby I think we can really justify this for using it to treat most of the patients that we see. And by understanding that physiology, I want us to be able to ultimately make the argument of why we should be able to use it additively with many of the other technologies that are emerging right now and with the more traditional manual therapy and exercise so that we could really use this needling in order to create better recipes to get better outcomes to ultimately increase the value of what we do as physical therapists.
High specificity. Absolutely. I mean, there's so many pathways at our disposal. It's just knowing what they are and how we can access them.
I mean, that was a whole lot of things. We could have taken each one of those different topics. I think, that could have been its own talk. But I think the purpose of this, and I hope I was at least able to accomplish the mission that, you know, I think the things that I just mentioned are really the high points of what you see in the literature of why dry needling is such a powerful tool.
I think that's a great place to leave it. I Thanks, Ray, for the time this evening and talking about pain and how we can really deal with that with dry needling. And I'll see you soon, okay?
Thanks, Bruce. Thanks for the time.
Yep. Take care.